Okay, we are back for the second half of chapter 15. Like I said, we're getting into a little bit more of the physiology side of things in this chapter. Okay, so the cardiac cycle itself is what is considered one beginning of one heartbeat to the beginning of the next, kind of what takes place in one full heartbeat plus preparation for the next beat. So we have systole, that's the contraction phase. That's when our ventricles are squeezing. And diastole is our relaxation phase. Our heart sounds usually kind of refer to the sound of the heart as a lub dub. So when it's beating, it's going lub dub, lub dub, lub dub. So S1 is a louder and longer. That's your lub. Your S2 is softer and sharper. So there are specific anatomical landmarks that you can hear these sounds at, but that is not important for this class. You don't have to memorize that. Okay, so on the right hand of your screen, we're going to go through a few slides that look similar to this for each phase. So remember, we talked about the different aspects of the EKG. Now we're going to actually match them up with talking about what's happening in the heart. So phase one, that's our P wave. You have your passive ventricular filling. So you have returning blood fills the atria, pressure increases in the heart because blood's filling up. The AV valves open, so those are our mitral valve and our tricuspid valve. So the atrioventricular valves open, blood can go from the atria into the ventricles, and that's kind of when our P wave appears on the electrocardiogram, is that transition, and that's the end of depolarization. Sorry, I should say atrial depolarization is. Okay, atrial systole or atrial contraction. We have our AV valves open, so mitral valve and tricuspid valve are open. The semilunar valves are closed. So that means, oops, sorry guys. So that means that our aortic valve and our pulmonary valve are closed. So the atria are going to contract. They get rid of any remaining blood in the that they're holding that didn't go passively when the valves opened. The ventricles remain relaxed, but they fill up. And so that's this section. So coming from our PR interval into the Q wave. Okay, phase three is the isovolumetric contraction. So this is as our ventricles begin to contract. We still have the aortic and pulmonary valves closed. At this point, our AV valves are going to close as well because we don't want blood going back from the ventricles into the atria. So that causes a fast increase in pressure. And so we get our R wave on the ECG, and that's also when our first heart sound occurs. Okay, and then we get to phase four is when our ventricles actually eject the blood. So our aortic valve and our pulmonary valve will open up. As the ventricles contract fully, the blood's going to push out of the ventricles into either the lungs or the body, depending on which ventricle it's coming out of. We do get a little bit of blood that does not make it all the way out of the ventricles. That's known as residual volume. And then we have our T wave, which occurs at peak ventricular pressure. So isovolumetric ventricular relaxation. So that occurs before the AV valves open and after the semilunar valves close. So this is before the tricuspid and mitral valve open again for the atria, but after our aortic valve and pulmonary valve have closed. The pressure in the ventricles has dropped a good bit. And then we have the end of our T wave on the EKG, and our second heart sound can be heard at this point as well. So if you want to go through that as more of an animation, just click on the link at the bottom here. It's this kind of the same concept. Okay, so I'm sure you guys have kind of figured this out by now, but the EKG and our heart conduction are very connected. The animation of the EKG really shows the relationship between the action potentials or the electrical signal passing through the heart and the actual contraction of the different parts of the heart. So here's a little video about EKG a little bit more if you're interested in that. Okay, so review question 4, what is the heart's primary pacemaker? So we have A, the AV node, B, your Purkinje fibers, C, sympathetic nervous system, or D, the sinoatrial node, your SA node. The correct answer is D, SA node. So remember, there's a few different structures that have their own rhythm or pace to them. Our SA node is in charge, so it's the right answer. That's the one that really drives everything. But if the SA node fails, the AV node can take over. If it were to fail, then technically the Purkinje fibers can initiate impulses. But as long as the SA node is healthy and functioning, they're not our primary pacemakers, and their rates fall kind of outside of what we would like our normal to be. So we really would prefer our SA node to stay in charge. And then our sympathetic nervous system, it can definitely alter heart rate, but it's not a pacemaker itself. But hormones and neurotransmitters from the sympathetic nervous system and endocrine system can definitely affect the heart rate. Okay, cardiac output. So this is really referring to the amount of blood that our heart pumps in 1 minute. So how much blood are we pumping out? So to get that, we need to multiply our heart rate by our stroke volume. So heart rate is pretty simple. That's beats per minute. So how many times our heart beats in a minute. The stroke volume is the actual amount of blood ejected from the heart with each beat. So we're really thinking the amount of volume that is pumped out of the left ventricle. The volume in the rest of the heart is important because that kind of has to make it to the left ventricle. But when we're looking at stroke volume, we're looking at how much the left ventricle can pump out. So usually when we're just resting, not exercising, not playing a sport, our cardiac output is going to be between 5 and 6 liters per minute. And the only way to affect cardiac output are to change the heart rate or change the stroke volume. So if heart rate goes up and stroke volume stays the same, then our cardiac output is going to go up. If heart rate drops and stroke volume stays the same, our cardiac output is going to go down, and vice versa. Okay, so this is just a little bit of kind of couple ways you'll see the equation itself. So that's it, just all the way written out. And here's your abbreviations that you'll see more often. So for cardiac output, if we multiply our heart rate, the 75 beats per minute times 70 milliliters per beat, the beats cancel out, and then we get milliliters per minute as our unit. So 75 times 70 is 5,250 milliliters per minute, but you will usually see it reported as liters per minute. So there's your 5 liters per minute. That's on the lower end of average for resting. Okay, some other factors affecting our heart rate. So our medulla and the brainstem actually contains our cardiac center, and that really kind of passively drives everything. We don't necessarily think about using our medulla to control our heart. That's not something we have to worry about. But our brain is working all the time to try to control our heart rate and blood pressure and that side of things. So the medulla has an acceleratory center. So that's going to have impulses via the sympathetic nervous system. Remember in our review question, we were just saying how the sympathetic nervous system can affect heart rate itself. So that's going to trigger the cardiac nerve to secrete norepinephrine, and that's going to go to the SA node, our pacemaker, the AV node, and the cardiac muscle, and that's going to stimulate a faster heart rate as well as usually a stronger squeeze as well. You also have an inhibitory center, and that's going to be more run by the parasympathetic system. And so that's actually triggers your, oops, sorry. That actually triggers the vagus nerve, one of our cranial nerves, to secrete acetylcholine. And that's going to cause a slow in heart rate. Some other feedback to help the medulla decide what to do in terms of heart control. We have proprioceptors in our muscles and joints, and that usually kind of can trigger if we're changing physical activity or if we're working a little bit harder. We have baroreceptors, which are pressure receptors. Those sit in our aorta as well as our internal carotids. Your carotid arteries run up in your neck. And so based on the pressure readings we're getting, if we have high blood pressure, low blood pressure, or right where we want it, that can stimulate the heart to beat faster or slower. We also have chemoreceptors or chemical receptors. Again, the aortic arch has a few of these, the carotids, and then of course in the medulla, and that can detect things such as increases in carbon dioxide, decreases in oxygen, and changes in pH. So they can alter stroke volume if they need to circulate more oxygen if we're running high on carbon dioxide. Okay, we're going to talk about these three factors individually, and these affect stroke volume specifically, not just cardiac output, but stroke volume specifically, and therefore cardiac output. Okay, preload. So preload is the amount of tension in our ventricular muscles before it contracts. So this is really determined by the amount of blood filling in. So the more blood there is filling the chambers, the more stretch you're going to get. If you think about a rubber band, kind of the more the stretch, the stronger. Okay, contractility is the force at which the ventricular ejection occurs. So preload and contractility work hand in hand. You do need to understand or remember that this is called Starling's law of the heart. So the greater the stretch, the more forceful the contraction. So if we have a pretty weak preload, then the contractility is going to be pretty weak. But if we have a good preload, which causes a good stretch of the ventricles, then we're going to have good contractility. And then afterload actually refers to the forces the heart is working against. So our right ventricle is working against the pressure of the lungs, and our left ventricle is working against the pressure of the aorta, or really it's working against the pressure of our bodies. So the more afterload that the heart has to work against, usually we're going to have a decreased stroke volume because it's got to fight harder to pump. This animation really shows a good visual of all three of these concepts, so I would recommend looking at that one. Okay, I think this is actually review question 5, but cardiac output equals A, heart rate times stroke volume, B, stroke volume times ejection fraction, C, age times heart rate, or D, the percentage of blood ejected by the ventricles with each contraction. The correct answer is A, cardiac output equals heart rate times stroke volume. Okay, now we're going to talk about the two different kinds of heart failure to wrap things up. So if the left ventricle can't pump against the afterload of the body or is having issues with backflow from the aortic valve or not filling properly, then blood ends up backing up in the lungs, because remember, the lungs are what sends blood to the left atrium. The left atrium goes to the left ventricle. So if the left ventricle can't get that blood out of the way, the lungs and left atrium have nowhere to send their blood. So typically the signs and symptoms of that, you have shortness of breath, pulmonary edema, which means fluid in the lungs because the blood's backing up. And then of course you're going to have some coughing because you have stuff in your lungs that is not supposed to be there. And then we have right-sided heart failure. So if our right ventricle falls behind in injecting blood, it receives from the systemic circulation. So it's not handling the blood coming in and back from the body and heart. So it backs up in our vena caves and as well as our peripheral vascular system. So it's not just backing up in the heart like left-sided heart failure, the heart and lungs. This is actually backing up in the body. So you get generalized swelling because your blood doesn't have anywhere to go. You can get an enlarged liver. Our liver plays a large role in kind of cleaning and cleansing our blood, so blood can get backed up there as well. Same thing with the spleen. It recycles red blood cells, so it gets backed up. And then you can also get some pooling of blood in the abdomen, so you get kind of a distended, swollen abdomen as well. Another clinical sign that's very common to look for right-sided heart failure is jugular vein distension, or JVD. Your jugular vein is up on your neck also. And when people have right-sided heart failure, because of the swelling, oftentimes you can see a pretty prominent jugular vein sticking out, and you can see that change as swelling worsens or improves. The jugular vein will worsen and improve as well. All right, so that was our last slide for chapter 15. Thank you for being patient. Sorry I had to re-record this one. But thank you very much for listening.